afternoon, everyone. As Steve said, I'm Sarah Almasian. I'm the Associate Director of Alumni Engagement and Participation here at the College of Nursing, and I'm thrilled to introduce today's on-duty speaker. Dr. Rebecca Singer is a clinical assistant professor in the college's Department of Population Health Nursing Science. As a professor and a clinician, Dr. Singer draws on more than a decade of experience in global health and community partnerships. For more than 6 years, she has worked in the field with Doctors Without Borders, focusing on providing care to survivors of violence, establishing primary health services for displaced people and refugees, responding to epidemics, and establishing emergency preparedness. She's also worked with Grounds for Health, establishing community-based cancer prevention programming in Latin America and East Africa. Here at UIC, Dr. Singer has been instrumental in establishing a community health clinical rotation for students inside correctional facilities. In 2020, thanks in large part to her humanitarian work abroad and her fearless human suffering, Dr. Singer stepped to the forefront of the college's response to the COVID-19 pandemic. She supported the campus by developing employee testing program. She supported the community by co-leading a team of health sciences, faculty and students who are conducting COVID-19 testing at homeless shelters, encampments, senior housing, and long-term care facilities under contract with the Chicago Department of Public Health. If there can be such a thing as a rock star of public health, Rebecca Singer certainly is it. Please welcome Dr. Rebecca Singer.
Wow, thank you. If only this were a stadium and there were lights, that would be exciting, but I'm not that type of rock star. Sorry to disappoint folks, it's just a PowerPoint. So I hope everyone's doing well today. All right, can people see? All right, so thank you so much for inviting me, Sarah and Steve. It's a real honor to be part of this series, and thank you all for taking time out of your busy day to come hear my talk. So like Sarah alluded to, I'm going to talk today about humanitarian response to a global pandemic and really sort of talking about how the experience and what's happening today in our own city has really drawn on my experiences overseas and how they have been woven together. So without further ado, I'm going to start with this quote from James Orbinski's speech, in which he was at the time the international director of Doctors Without Borders, and that was the year that Doctors Without Borders won the Nobel Peace Prize. And I like this quote because it really, for me, encapsulates what it means for me to be a humanitarian worker. So, you know, when people often ask me, like, what does that mean? What does that work do? How does it speak to you? Why does it speak to you? I feel like I'm just going to channel someone who is much more eloquent than I am, and the words of James Orbinski. So our action is to help people in situations of crisis, and ours is not a contented action. Bringing medical aid to people in distress is an attempt to defend them against what is aggressive to them as human beings. Humanitarian action is more than simple generosity, simple charity. It aims to build spaces of normalcy in the midst of what is profoundly abnormal. More than offering material assistance, we aim to enable individuals to regain their rights and dignity as human beings. And I think this really speaks, whether I am swabbing noses in Cook County Jail, like I was just an hour and a half ago, or whether I'm trying to provide primary care to people in Cameroon during an emerging civil war. You know, really, it is an effort to help people regain their rights and dignity as human beings. And the other piece of this that really speaks to me, I love my work. I am passionate about it. I mean, I don't know if any of you know me personally. I know a lot of you do and know that I am passionate about a lot of things, but I'm extremely passionate about the work that I do doing humanitarian response. Yet it is not a contented action, and that really speaks to it. If only I could work myself out of a job, that would really be my dream come true. Then I'll retire someplace warm and mountainous and sunny, and that'd be great. But instead, we keep on moving. So this is a map of the world showing various places I've worked, mostly with Doctors Without Borders, but also with Grounds for Health and another coffee organization that I worked with, Coffee Kids. So I like to say that I have worked on 6 of the 7 continents. The only one I've not yet worked on is Antarctica. So I'm trying to figure out how to do that. But unfortunately, they don't have too many humanitarian needs there. The work I have done has mostly been with Doctors Without Borders, or MSF, which is an international medical humanitarian organization that provides care to people in distress as a result of either man-made or human-made or natural disasters. So floods, earthquakes, war, famine, epidemics. This is the type of work that we do wherever it happens around the world. And we're known for sort of going that last mile. Most of the work I have done has been in extremely low resource settings, although some of our projects in the Middle East, especially, are much more high tech and sort of higher level. I have always been the person who works the back of the beyond, the place that we look at that map and say, who's there? You know, no internet, no electricity, no running water. But lots of people with really important healthcare needs. And it gets to the sort of my adage that where we live should not determine if we live. So the humanitarian principles that MSF works towards and which guide my work in general are impartiality, neutrality, independence, and medical ethics. And I'll just briefly break this down for you. So many people think impartiality, neutrality, same. And they're similar, but not quite the same. So when we talk about neutrality, we're talking about not taking sides in a conflict in a conflict. So what this looks like in practice is, for example, I worked in South Sudan. I worked in the northern part of South Sudan, which if Kathy's screen was on, she'd be giggling right now because she likes to talk about how I worked in some crazy northern, southern South Sudan in the north. That's what I did. And the Nile River there is the front line. On one side is the government forces, on the other side were the opposition forces. And MSF very deliberately set up healthcare programs on both sides of the river in order to meet the needs of both sides of the conflict and to show that we are neutral. We're not taking sides. There are health needs here, there are health needs there. That's what's important. Impartiality is slightly different and refers to our policy of non-discrimination. So while we do have criteria for entry to certain projects, we're only taking care of children under 5, we're only taking care of pregnant people, we're only treating people who have TB. The fact is that we're not any further than that. We're not saying you are, a member of this group, you have these political beliefs, you can't come in. We're not interested in that. We don't allow people wearing military uniforms or carrying weapons in. But other than that, if you have a medical need, come, help. We will serve you. This has ended up being challenging for us in times. In 2015, in Kunduz, Afghanistan, one of our hospitals was bombed by NATO forces. And when sort of asked about why, they were like, well, you were harboring Taliban, weren't you? And we're like, we don't know. We don't ask people, are you Taliban? Are you not Taliban? We're just going to help whoever has needs. And so that's our, based on our medical ethics, right? So then finally, we're an independent organization. We get to decide where we work based on our conversations with the community and based on the needs that we see. Now, we do respond to being asked, like a government calls and says, hey, we have a measles outbreak, come help, sure. But we're going to use our resources and our know-how to really assess the best way to do that work, the best place to do that work. And sometimes it means saying, no, you want us to do that over there, but that's not where the need is. The need's over here, right? And so we're going to work over here. And we can do that because we are, at least before this year, before the economic downturn, a $1 billion organization. Sorry, Steve, I know that that's what you aspire to at the College of Nursing, but and most of that money is independently funded. So it's not from governments. We don't take government money, only in very, very limited cases, because we don't want governments telling us you have to do this and not that. I'm sure everyone is aware that money that you take from the US government, from US aid, has lots of strings attached to it, especially in areas of family planning. So we provide abortion care, not because we're pro-abortion, but because we are pro-family and pro-safety and pro the life of a mother. And so we will do abortion care to save a life, and we're not going to not do that care because the US government tells us not to. So that is how our independence plays out. And then finally, we all rest on our medical ethics. We are an international staff of tens of thousands of people. The 90% of the people that work for MSF work in the country of origin. So when I work in Congo, I am working with Congolese folks. When I'm in South Sudan, it's South Sudanese folks. 90% of my teammates are from that country. And so we all come at it with a different cultural background, with a different knowledge base, but we all adhere to the medical ethics put forth by our profession. And that is what ties us together and allows us to do that work in a way that's effective. So what does this look like in action? Well, when we put those principles in action, we're responding to emergencies, and emergencies can be determined in the broadest sense of the word emergencies. So we do primary care, a lot of primary care, right? So this is a picture from an internally displaced persons camp in South Sudan, and we were doing primary care services. And then what we often do, because we didn't have secondary care there, we were referring patients and paying for those referrals to a place where they could get surgical services, right? So if we can't provide the services, we try to provide referral to a secondary or tertiary care center that might be able to provide that higher level of care. But we're going to do the best we can to provide the care in place. We do some specialized care. Sometimes it's specialized care in the context of a wider project. So we can do HIV care, TB care. In this case, we were doing HIV, we were doing TB, and we were doing Kala-Azar care, leishmaniasis, but specialized care for those services. But sometimes those are vertical.
Cards everywhere. Who needs credit cards? Credit for
that there's such a challenge that
so what I want us to do
that we're going to provide a vertical project. We also respond to outbreaks, right? So famously, we responded to Ebola. Right now, all around the world, we're responding to COVID. I've been involved in several responses to both measles and cholera, especially doing vaccination. I was once in Congo in a very, very, very remote region, responsible for a team of, I think it was 300 folks, and we vaccinated over 70,000 children in about 15 days. And this is in a place with no roads, no electricity. Anyone knows anything about the measles vaccination, it requires a very good cold chain. Not as good as the Pfizer vaccine for COVID, of course, but it is required to keep it at a very cold temperature. And so these are all those logistical challenges, and then going out into places where there is people don't always trust healthcare workers, and persuading people to get vaccinated. And then providing the care for those kiddos that did get the measles, unfortunately, prior to our ability to vaccinate them. We also do a lot of work with malnutrition. So helping feed babies and keep families safe and fed, especially during crises. Famine is a man-made disaster. Always, it can be because of drought, but it's only because people make choices. Governments make choices about how to distribute food and water that we have famine. And so our work is to meet those needs. And then always we do mental health care. When I first started with the organization, we didn't do mental health care very much. It was only in very specialized areas, in the sexual violence response area, which is where I've mostly worked, or in TB or HIV. Now we're seeing it everywhere. When I was in Cameroon in 2018, we were assessing it and trying to figure out what type of programming to do, and we're meeting with people and providing primary healthcare as a way to do an assessment. So we would do mobile clinics, go in, do consultations, and really almost everyone was suffering from mental health issues, from things like headaches, insomnia, belly pain, body aches and pains, which are all somatization of the trauma that they were experiencing as they went from being a farmer, a teacher, a lawyer, to being homeless and living rough and fleeing for their lives. And so I called our headquarters and they're like, we're sending the midwife. And I was like, we don't need a midwife, we need a mental health specialist. And so really recognizing that there is no health without mental health in these cases. And then the second piece is bearing witness, which is really important. I'm sure everyone in this room, if you're a nurse, you're like, yeah, advocacy, that is a main part of our job. And that really is. But I think that there are a lot of healthcare workers and lots of organizations out there that are so focused on that care and on providing the clinical care that they don't realize that part of our job is to do that bearing witness. First of all, just being with people, bearing witness, taking note and acknowledging their suffering is a way of alleviating it. But also, I've worked on several advocacy campaigns in which we gather information and we use it to advocate for change, that we amplify the voices of the communities that we're working with, we work with them to determine the messages and help get those messages out. Work that I've done in Liberia on sexual violence and Papua New Guinea on sexual violence has led to major changes in how the government has funded and implemented sexual violence response in those two countries based on our experiences and the things that we saw and that we shared with those governments and donors. I talk all the time about this work and I'm really passionate about it, but it does have its challenges, obviously. And those challenges are real, right? So one, when you do humanitarian response, really limited impact, right? You're going in to fix a crisis. There's a crisis, you're going to alleviate the suffering right then, you're going to meet that need, and then you're going to get out, right? So you're really caring in the moment, but you're not really looking to cure or to solve the problem big picture, right? We're not looking for that systemic change that is actually necessary in order to solve the problems. If you're someone like me who thinks systems-wide, that can be extremely frustrating. And so sort of having to focus on that person in front of me, that community in front of me, really is helpful, but we are limited in our impact. Sometimes we have to provide substandard care. It's not because we want to, it's not because we think it's okay that these are children lined up for that vaccination campaign in the Democratic Republic of Congo. It's not because I think that they deserve less than me and the children I know here deserve, but it's really because there are such logistical challenges, because their governments don't allow us access. We can't get the medications in. The medications aren't on the national formulary, even though we know that they're better. That's the World Health Organization standard. That government's not going to let it in. They're not going to let us work with our protocols. They're going to insist on their protocols. Sometimes I've worked in, when I was working in South Sudan, if it rained, we couldn't land on our landing strip for 3 to 4 days. During a rainy season, when it rains every 3 to 4 days, that's a problem. And at the time I was there, like I said, the Nile River, which was the front line, got closed for several weeks. So we had no way in and no way out when it was raining. And we were running out of things, right? So oftentimes it's a supply chain issue that leads us to have to give that substandard care. And that can be really challenging for someone who wants to deliver excellence at all times. One story I often tell is I was working in Chad, in the very, very, very most rural region of Chad. And I was working with a pediatrician who called me over because she saw something, she didn't know what it was. And it was an adult woman with, and she took down her dress and her breast was peau d'orange. I'd never seen it before. I'd only seen it in the books. I was like, that's breast cancer. Like, that's what that is. And just knowing there was literally nothing I could do except give her 6 ibuprofen, 12 ibuprofen, and send her on her way, because there was no referral hospital in the country. It's not even clear that there was radiation therapy available in Chad at all. So even for love or money, we couldn't have gotten her the care she needed. And that can be really challenging to sort of face mortality like that and to see that indeed where you live does determine if you live. And then obviously, which we see right here in our country right now, and I'll talk about that later, needs outstrip resources, right? And that's really common and really challenging to witness. Another challenge is that we work in broken spaces. By definition, when you work in a humanitarian crisis, that is a broken space, right? So, there's limited safe spaces for humanitarian actors. I alluded already to the bombing of the hospital in Kunduz, Afghanistan. I have worked in many places where we have been targeted, where the place I have worked has been targeted, where healthcare workers in general are targeted, and that as that space shrinks and the respect for healthcare workers as neutral disappears, it makes it more and more difficult to reach the populations actually in need. And it's weaponized, right? That we become part of the conflict, in which getting rid of the outside observers, the humanitarian organization, really is a weapon in the war. One thing is working in a team, I said 90% of my colleagues are from the place in which I work. So that means that not only are they healthcare providers in Congo, but they are people who are also experiencing the trauma of Congo, right? And the war, whatever, name your country where there's a war. My colleagues are also essentially beneficiaries of the care that we give. And that can be really challenging when I'm saying, like, you need to get to work on time. And they're telling me that, you know, they're worried about feeding their family. They're worried about getting their family to safety. They're worried because there's not enough food, and they ran out of, they ran out of the cash because of inflation and food shortages. And I'm like, work starts at 8. And so that can be really challenging to sort of navigate that and to run projects when you know that your colleagues are suffering as well. And that sort of gets to that impact of the ongoing trauma that they experience and that we experience and witness. And that can be really challenging to be a witness, knowing that I have my privilege, right, is my passport that I get to leave at the end of the day. And then finally, there's often that focus on humanitarians and not the humans, right? So, wow, the work you do, Rebecca, is amazing, and MSF, or we hear about that. And we're not really thinking, though, about what happens behind that. Why am I there? Why are these humans suffering? What sort of geopolitical and economic forces are leading to this war, to this devastation, to this deprivation, to this lack of access to care, to substandard care, to all those things? That's what we should be focusing on, not the sort of amazing work of this international organization. And it is amazing work. I'm not taking away from that. And then finally, the personal is professional, or the professional is personal. When I'm overseas, I live and work I'm there 24/7. That's what I do. And it's a constant sort of thing. You're isolated, you're far away from home, and often running into people that really have funny ideas when you're a foreign worker doing this work. People who really feel like, go in with that idea that my education, my privilege in this country, I am the white savior, right? Like, I'm going to take my awesome education from the top nursing school in the country at UIC, and I'm going to go show those people in Congo how to do it. Here's my colleague in Congo, Georges, who knows far more than I do. I mean, way more than I do about malaria, right? And so really, I am there to support him in the great work that he does. But if you go in there thinking you're going to save the day, then you're just, that's really problematic. That can also be problematic because you get there and then there are people doing this work, and that can be really disheartening for people who do it. And then finally, I won't go into it very much, but we talk about humanitarian workers falling into a couple different categories: martyr, mystic, mercenary, misfit. Which one am I? Those of you that know me, you can point a finger and cast aspersions, label me at will. So for years, I did this work. It was something I did during the summer. It was something I did overseas. I've done it since 2005. It happened far, far away. And I always would joke that my skills in the United States were kind of useless. Like, I wasn't a very helpful nurse in this country because I only knew about malaria, sexual violence, and, mobile clinics, none of which were relevant here, right? And so my family joke is that I wasn't much use of it as a healthcare worker. But suddenly, in March of this year, I became relevant, which, that was nice, not for the best reasons. But it's been interesting thinking, and I fall among those in our country that had the hubris to think that we would be able to handle anything, and that we could do anything, and that we would know how to do it and do it better. And the fact is that I never thought that I would see such a disorganized response, that I would see us unable to meet a crisis, that we would not have the PPE. When I worked in South Sudan, we shared N95 masks. There just weren't enough. We had a TB patient, and we had a TB tent, and we would share N95 masks and reuse them. And there I am writing to headquarters, like, we need more N95. How is this? This is not okay. But never thinking that that would happen in my own country, where I'm putting little check marks on my N95 because I know I have to use it 5 times. And suddenly that is where we are here in this country. And while it has been terrible, it's also been amazing to be able to see how people have stepped up and started doing the work and really taking those humanitarian principles that I've worked with and under and applying them here at home. So as Sarah said, I've worked on 2 projects since COVID started. I helped them set up the employee testing center at UI Health, and I did that for a couple months. And then I transitioned since then to a project that is in collaboration with the College of Medicine and Rush University, actually also, and CDPH, the Chicago Department of Public Health. And we are a contractor with the Chicago Department of Public Health, doing testing in all those congregate settings. So in homeless shelters, in correctional facilities, in behavioral health facilities, in long-term care facilities. So in a variety of places where people live together, and it is harder to protect each individual person. And also I'm also getting involved in a study, an NIH-funded serological study to try to understand how COVID has spread through our community. So when I think about the work that I'm doing here on COVID, I think about those challenges, and they're the exact same ones, right? I find myself, although I'm in Chicago, and sometimes I'm in the far north side, sometimes I'm in the far south side, sometimes I'm in central Chicago, sometimes Streeterville, wherever I am in the city, it's the exact same challenges that I faced in Cameroon, in Haiti, in Congo, in Chad, in Uganda, right? That what's happening on the outside is different, right? I'm not facing a armed struggle. I'm not facing rebels. I'm not facing in the case of a malaria outbreak, an outbreak of something I don't know anything about. I'm not facing, well, I'm facing some poor infrastructure, but not to the extent we have poor infrastructure in places like Congo. But it's interesting because we are facing those same challenges. When I think about what I'm doing, we're testing 1,000 people a week on our team, 1,200 people a week. With the vast needs in terms of our needs for testing, we have fallen behind in our city. We were a state that was doing really, really well in testing. And if you look at the city dashboard over the past few weeks, our increase in cases is far outstripping our increase in the ability to test. So really, having that limited impact, really only being able to test this small amount of people and hopefully, stop not a big outbreak. But I've been saying the last couple of weeks, I feel like there's a tsunami coming, and I'm doing like this. Got it, right? Like that tsunami's not going to stop because my right hand is going to hold it back. And that can be really challenging. I think, one thing that we are living in a broken space. We are experiencing collective trauma right now, that all of us have suffered some sort of loss. Maybe the loss of a loved one, maybe the loss of a colleague, a friend, a family member. Maybe some of us have lost jobs. We've lost income. Family members have lost income. Some among us have probably lost their home. So that, there's all those individual losses, and then also the loss writ large of the way of living that we had. There was lots to critique about the way of living, but I don't think anyone can critique that it was a good thing to be able to gather around the table with family, to be able to go to movies, to be able to go hear live music, live theater, to go to museums, to go to a park, to play games, to have our children go to school and have play dates. None of those were things that were bad, right? And yet we have lost all of that. And that is really, we are living through that collective trauma, and it will take us a long time to get through that and to process that. And I think we all have to recognize that. And it's hard as we push through and be like, I got to get to work on time. Like, my broken heart is not a reason that I shouldn't have to get to work on time. But some days, like, I don't want to get to work on time. I need that extra time to sort of process what's going on. And so I think that really we are all living that. And we all have to be gentle with ourselves and recognize that in others, but also just recognize that that is what is happening right now. All hubris aside, we are experiencing that trauma. And then finally, the personal is professional and the professional is personal. None of us gets to leave COVID behind. So maybe I leave the jail, right? Like, so I left the jail and I'm now in my lovely home and I get to do other things. But COVID is always there, right? The restrictions are always there. The thought of it is always there. I'm always projecting, like, how many more people can we test? How many more people are going to suffer? What will the next 4 months look like? When will the vaccine come? You know, there's no escape. When I worked overseas, it was really nice because at the end of the day, I could read the news from home, and it wasn't always good news, but it was different. I could escape. I could think that at the end of this, I'm going to go home. Right? I get to go back to my cute little apartment in Chicago. I get to go back to Pilsen. I get to eat the food. I get to go running in the Palos Park. I get to do all sorts of fun things. And now, you know, we're living the dream. This is how it is right now. And there is no escape from it in that way. And it's really adjusting how we think of our lives in this humanitarian crisis to be able to readjust those sort of desires and aspirations, and to understand that our limits are different right now. And so as I do the work, which I love, like, I mean, who knew I would love swabbing people so much? But I really do love it. I love going into places, meeting people who are experiencing a crisis. They're afraid, they're concerned about COVID spreading. And it's really great to be able to go, put on my PPE, work with an amazing team of colleagues, students, nursing students, med students, physicians, dentists, public health folks, people from all over the city volunteering and their time, or some of them we pay, and really getting to do this work. It's fabulous. And I feel so happy to be able to contribute in some way that I do have those skills to be able to make a dent in this humanitarian crisis. So I'm going to stop there, and I wonder if there are any questions or comments.
Thanks, Dr. Singer. Let's open it up for Q&A. Please type your questions in the chat field right now. Let's see. From Kathy Yonkaitis, she says, thank you. What do you see as the biggest the biggest challenge to nurses if you could pick one?
In general or right now?
Let's see if she
right now in COVID.
Okay, just making sure. Wow. I think right now is this weird thing. So nurses, right? We are the most trusted profession. At the beginning of this crisis, we were seen as heroes and heroines, and that we were the people doing the front line. Thank you, thank you, thank you. And I think that the challenge right now is that, I mean, it's all related, but it's that everyone is really tired of COVID, right? And so people are poo-pooing it. People are not adhering to the things that we know will prevent the spread of COVID. People are disregarding nurses and physicians as well, but nurses' guidance. And I think that fatigue that we feel is a real challenge right now, because actually, I think that the hardest part, I've said this a lot recently to my colleague in the College of Medicine, Dr. Mayer, that like we didn't know that we had a break, right? And I think that that's the same for nurses everywhere, wherever they're working right now. We did not know we had a break. And so we don't feel like we had a break really. And now we're heading into that next phase. And maybe this will be, you know, let's hope vaccine will be producible and we'll get it out there, but we still have another 4 months ahead of us that are going to be really rough as this surge hits. And so I think fatigue, just general compassion fatigue, burnout is the biggest challenge right now for nurses. And that is because of the rise in numbers, the lack of buy-in from the public, and the doubts and challenges that people are getting from the public.
All right. From Carla Ginny, what experience abroad is most similar to what you're doing on the home front to confront COVID?
Oh, wow. I think in terms of like literally like logistics, like getting a team together, getting the stuff together, heading out, doing the work, boom, 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 turning around and coming back, it would have to be probably the measles vaccination campaign that I did in Congo. Because it was the same sort of thing. We had a base every day. We loaded up the cars, we loaded up the motorbikes, we loaded things onto people's backs, and we marched out to meet the needs of the community. You know, got in a community, set up, did the work, broke it down, came back, woke up the next day and did it all over again. So in some ways, that sort of way of doing the work, I've actually always loved doing mobile clinics. That's like my favorite thing to do with Doctors Without Borders, with MSF. And so here I get to do a mobile clinic every day, which has been really fun. The other thing though, sorry, is that the other day when I was feeling a little down and being like, Singer, you've been to like the worst places. Like you've seen war and you've experienced war and you've like taken care of refugees and you've been here. Like think, dig deep. When has it been this bad? Like when have you seen like there is no up? Like, and you got out. Like it was there. And I was like, no, this is the worst. This is the worst. And I think that that's been really humbling for me, and sort of like, I got to get deeper down that well in order to get it up, to like get up the hope and to keep going. And I think that, yeah, that's really challenging. And I think that, I think that I don't think any of us, and this is not just me, this is all the people on my team, this is all of you, I don't think as healthcare workers we have ever worked this hard and failed this badly. And I think that that's really challenging. But big picture, I've worked in places like Liberia, which got decimated by a civil war, brutal, like you can't believe, and everything really, all parts of normal life destroyed. And yet I worked with amazing people who were rebuilding and coming to work every day and laughing and telling stories and listening to music and dancing and caring beautifully for patients. And so that does give me that hope that even in that depths and like seeing the worst, that we can do it and we can keep going.
From Cherise Smith, of all the places you've served, which one has been your favorite and why?
Oh, wow. So, the first is always your favorite, I think. I worked in Liberia. That was the first overseas assignment I had with Doctors Without Borders. And I fell into an amazing opportunity where I worked to establish the first rape crisis center in the country. And I was there at a really particular time where I was able to be really involved with a big group of people in rewriting the laws around sexual violence. I was involved in prosecuting the very first case of for sexual violence in a decade. I was involved in setting the protocols for the country and just really did amazing work with lots of communities and just really engaged with working with a whole string of young girls mostly who had experienced sexual violence and being able to do that work to help them in this really rich place of Liberia that had suffered so. And so I still look back. First of all, the work was amazing. My team was amazing. So I've always loved that work. In terms of my favorite place generally, because it's just so darn beautiful and the staff are super, super, super well trained and smart and funny, is Congo. Eastern Congo is amazing. That's a picture of us driving into the jungle in Eastern Congo. It's just a beautiful place and I have so many fun memories from there. I mean, a couple summers ago, or a couple years ago now, I was working at a malaria intervention that like every day we would hike 2 hours, set up a site, treat people, like literally save lives, hike back, camp out, and like sleep in a tent. I was like, I am living the dream. Like, this is amazing. And no internet, no phones, no electricity. It was fabulous. I loved it. So I could go on and on. Every place has its own flavor.
From Linda McCreary, what are some specific ways that we as nurses can help to change the helplessness we feel by getting involved?
Wow. Woo. So I think, oh, geez. This is something I'm really struggling with, right? So like, obviously I do this hands-on thing because that's what I know how to do. Yet when I try to talk to some of my own family members and talk about like, we just have to keep, minimizing our contact and just have to keep wearing our mask, I am coming up against the sort of like, it doesn't apply to me. I can do what I want. This is what I want to do. It won't be so bad even if I did get it. And I think that that's really challenging for all of us, right? That I think that we, as nurses, and I think it's back to that trust thing, right? Is that we are used to people listening to us. And so that's really, really hard to not. I think that what we can do is offer support to each other, right? So first of all, keep passing the public health word, like in a way as like unpreachy as you can, in a way that people can hear it, validate that we all get to make our own decisions. But I think that for those of us on the front lines or that want to be on the front lines, get out there. And for those of us who don't or can't for a million different reasons, like there are roles, we all have to keep doing this work. Everything else doesn't go away. So continuing to do that work and then supporting our friends and talking to each other and just keeping, I just get texts from friends that are like, thinking of you, good luck today, stay safe. And I'm like, okay, I can do it another day. And I don't think we should overlook both the small and the large gestures that we can make to get through this.
All right, from Leah Kellerman, how do you work to educate people who do not fully understand cause and effect as it relates to the spread of COVID? Example, wearing a mask over your nose, not gathering with other households, etc.
Yeah. So, I'll give you an example of what happened yesterday. So we were testing at a single room occupancy up on the north side. That was part of a collaborative effort that has a homeless shelter and a bunch of SROs and cooperative living. And a woman came down and you're like, mask here, and says, I'm not getting tested. I've been tested before. I was tested 2 weeks ago. I was negative. I'm not getting tested. And, I'm like, okay. And I just said to her, I was like, I get it. Yeah, we're all tired. Can we talk about it? And she was like, we can talk, but I'm sure you're not going to tell me anything my doctor hasn't told me. And I'm like, okay, cool. Let's talk about it. When did you get tested? Okay. You were negative. Awesome. So glad you're negative. So I can see how many times have you been tested? Oh yeah, I get it. Like you don't want to be tested. I get tested every week. I don't like getting tested either. So I totally get that. And then just like gently explaining, like, we only know right now if you're positive. Like, I hope you're still negative, but we don't know because last week's test doesn't apply to right now. Finding out like what's the barrier? Why are they not wearing their mask above their nose? Why are they don't want to get tested? Why do they want to? And sort of gently engaging, but also really validating, I think, because I am constantly saying, yeah, I hate getting tested too. Yeah, this really stinks. Yeah, this is like crap for all of us. I'm tired. I am tired of COVID, and just really validating all of those feelings and then standing strong on the things that we can stand strong on. One thing I love about my job is I actually get to tell people to put their mask on. I love that because when I'm in public and their mask is down here and I'm just like Rebecca Singer walking my dog, I'm like, ooh, I can't say anything. So that is really nice to be in a place where I'd be like, can you put your mask above your nose? Thank you. Thank you for coming to get tested. Can you put your mask on correctly? It's so, feels really good. So.
Walk your dog in your scrubs, Rebecca, so that you can tell people that they should put their mask on correctly.
Exactly. That's what I'm going to start doing. Yeah. I think we have to be gentle, right? And then the other thing I do say, and this is in talking with my family members, I'm like, we're all making decisions that work, best for our mental health and for our relationships. And so we all have to measure the risks to us. And 1 in 15 people have COVID right now in the city of Chicago. And that's really scary. And so like, wedding, they're sort of validating how hard it is to make these decisions, and then hopefully giving them information that helps them make it. And then the other really hard thing is like, if people aren't adhering, like, I'm sorry, I can't see you right now. You know, like I have to distance myself from you, which is hard. That sucks and gets back to that compassion fatigue and challenge.
All right. From Caitlin Canatello, where do you feel the U.S. could have done better in regards to COVID preparation and action early on? If you were able to go back in time and call the shots, what would you have done differently?
So if I were queen of the world, a game I love to play, I mean, I really, it is as simple as that we had leadership that recognized that COVID was serious, right? Like, honestly, that is all it would have taken. It's just a recognition that this is serious. This is a disease we don't, you know, it's an infectious disease that we don't know anything about. It's novel. What we do know is it's contagious. And what we do know is that some people are dying. So let's all pull together to do the best we can. And I think really it's around messaging. Yes, we needed more testing and they screwed up with testing. Yes, we needed, you know, better distribution of resources and PPE. I definitely would have like, you know, increased PPE production. But I just, honestly, the number one thing is we've lost the battle on public health. Everyone's like, why can they do it in XYZ country? I'm like, because people believe their government and people have a sense of collectivism. You know, we're really challenged. I think our rugged individualism is an amazing thing about our country. It's an amazing thing about people who live here. We are a bootstrap sort of folk, and we like pick yourselves up for good and for bad. And I understand all the sort of inequities and that the bootstraps does not work. Believe you me, I teach community health. Like I know all that, social determinants of health. But that attitude can be fabulous. And that attitude has screwed us so much in this country because people think it's my freedom to endanger other people's health. And we lost it on that one. And I think that truly from the start, if we had had better messaging, we would have mitigated some of that. Yeah.
From Karen Goki, do you speak multiple languages? How has your experience with communication barriers? How has that been?
Yeah. That's a fabulous question. So I do speak French and I speak Spanish-ish. And I speak some words of Arabic. I have a basis in Arabic. I've learned some, so every place I've worked, I've learned enough to sort of be dangerous for sure, as well as enough to sort of make a connection with people. Sometimes I can do like at least a quick analysis of like diagnostics in that language, even if I can't understand anything else. I could be like fever, vomiting, diarrhea, like I could do all that. And then the fact is that 90% of the people that I work with are from that place. And so if our own staff doesn't speak English, we always have interpreters or French. We always have interpreters that work with us, but also most of the direct care is provided by the people from the countries in which I work. So I'm doing quality assurance, I'm doing management, I'm doing supervision, I'm doing sort of the back level work because it's not appropriate for me to be providing care when I can't even communicate with people. I can't tell you how many times I've been placed and they're like, I want to see the white doctor. I'm like, the white doctor knows nothing. You do not want to see the white doctor for anything other than a cup of tea, because like Dr. Innocent over there, he's the one who knows everything about what you're experiencing. I also did learn how to speak Liberian English, and I learned how to speak talk pidgin in Papua New Guinea. So like I've always been able to like learn enough of the language to be welcoming and welcomed, and to be able to do greetings and stuff like that, and to build relationships depending on how long I'm there. But that is a very real challenge, and why, like I said, most of the direct service provision is done by people from that country.
Vanessa Rao was asking, how do you get involved with Doctors Without Borders?
Fantastic question. So you can go to doctorswithoutborders.org, which is the website for MSF USA, and to become a deployed healthcare worker, you have to have 2 years of experience in your field. So you have to have practiced nursing for 2 to 3 years. Ideally, you do speak another language, either Arabic, French, Spanish fluently, because that will help you get deployed somewhere. And then you also have to be willing to give a year of your life. Now, you might not get sent somewhere that first year, but they do want to know that you're interested and willing. And then finally, you do have to have some sort of experience in extremely low resource settings, or overseas experience, or working with extremely vulnerable populations here. So things like Peace Corps, National Indian Health Service, working in low resource settings here helps a lot too.
All right, Donna Huddleston, how do you keep motivation with limited impact?
So I am forever hopeful that like it's just gonna get better. Like I'm gonna keep doing it. Eventually, I'll wear away at it. And then also every day when I'm doing this work, I also have that, like, I take the big picture, and then I focus on the narrow, right? So yesterday, by the way, that woman who was like, I'm not getting tested, I persuaded her to get tested. Like, that was the victory yesterday, right? And so I think about that woman, and I think like, okay, I got one other person tested. And it's by narrowing down and focusing and on those moments. My nursing training, I was trained at the University of Colorado the first time around, and I worked with, and the school that I went to at the time was really, really imbued with the philosophy of Jean Watson, the healing, caring sciences. And so the focus of her philosophy, and the one that our school focused on, was really looking at the opportunities to create healing, caring moments. And that those opportunities exist in every single interaction we have with patients, with colleagues, that we can create those moments. If people aren't familiar with Jean Watson, it's a similar issue that Martin Buber talks about, or the similar idea of I thou, that relationship. But that also keeps me motivated, right? That by having those moments and creating those moments in which I bring my full authentic self to the engagement, they bring their selves, and we are actually creating something together, even if it's for 30 seconds, or maybe it's for longer. But that ability to alleviate suffering in the moment, and to transform both of us by having a meaningful engagement, that's what keeps me coming back. That's what keeps me motivated. That's what keeps me doing the work, even when like things are falling down around us, the sky is falling. Having that moment with someone is really powerful.
All right, Helen Miranda was asking about funding sources, if it's 100% self-supporting.
MSF?
I imagine that's what she means. I tried to dig for further info, but.
Yeah, so the work I do now is funded by the US government, so I'm doing COVID testing. But MSF is they do fundraising from individuals. So people like me, people like some of you out there probably donate. And so it's lots of small donors and lots of individuals and individual donors. So it is 100%, in that way, it is 100% self-sufficient. And so almost 95% of the budget right now is non-institutional funding. So meaning not even grants or government. So it's very high levels of individuals. We have some big picture donors, people who have, donate $1 million a year, or, more than that. And then lots of people who donate $18 a year, and put it all together, and you have $1 billion organization.
All right, and so our last question from Carla Ginny as well. What do you do for self-care when working abroad versus when working here?
Yeah, that's a great question. So I am, anyone who knows me, I love to exercise. I have a lot of energy, and so I need to sort of dispel that energy somehow. So I do yoga, I do workouts, and if I can go running, that's my favorite thing to be able to do, is to like run through these super remote villages, being like, hi, hi, hi on the street. It's amazing, beautiful places, like the best trail running. And if I can't do that, I do, Johnson & Johnson has this amazing app called the 7-minute workout. They're not all 7 minutes. And then I do a series of that. I jump rope. I read a lot. I read 19 books this summer. I worked in Haiti. And so that's something I can do for self-care, a way to escape. Yeah, so those sorts of things I can do when I'm abroad. Here, it's interesting because like the things that I did do here for self-care are also no longer available to us here. And so at the very beginning, so I always go to movies, I go hear live music, I go to live theater, and obviously those things are out. At the very beginning of COVID, my MSF friends and I were laughing that our COVID restrictions here in the United States were basically the most non-restricted MSF mission I've ever worked on. That, everyone's like, lockdown, this is terrible. I'm like, this is like the least I've ever had. So I feel well equipped to have dealt with this here. I get outside. That's my number one thing, is get outside. So.
All right. Thank you once again, Dr. Singer, for not only all of your amazing humanitarian work you do abroad and locally, but for taking the time to share it with us today. I know we all enjoyed hearing it. Also, I'd like to thank all of our guests for joining us today for our webinar series on duty. Please visit go.uic.edu/news-events to see upcoming events in this series. Our next one is Tuesday, January 19th, with our Associate Dean for Equity and Inclusion, Dr. Phoenix Matthews, who will discuss developing the pipeline to increase diversity, equity, and inclusion in nursing. Giving Tuesday is fast approaching on December 1st. We hope you will consider making a gift to support your alma mater. We're also currently accepting nominations for our 2021 Alumni Awards. Please consider nominating yourself, a former classmate, a colleague, by our February 1st deadline. For more information on these or any of our alumni activities, please be sure to visit our alumni website at nursing.uic.edu/alumni. Again, our thanks to you for being with us, and have a great rest of your afternoon.